Good morning, ladies and gentlemen. We welcome you warmly to the 229th session of the BT Sunday webinar series organized by the Society for Health Research and Innovation. Today's topic of discussion is management of dengue hemorrhagic fever, which is a very timely topic. And to conduct the lecture, I'm honored to introduce Dr. Nalin Kitulwatte, pediatric intensivist of the Lady Ridgeway Hospital for Children, Colombo. He is the first board-certified pediatric intensivist in Sri Lanka and is well known for and respected for his clinical excellence, compassion, and leadership in pediatric critical care. Over to you, sir.
Good morning, everybody. So we are going to discuss about a very important topic these days. Again, we are seeing a lot of dengue patients and some deaths also. That's why I selected this topic to discuss at this time. So topic today is management of dengue hemorrhagic fever in 2025. So obviously, this is for pediatrics. So in pediatric dengue management, we have published 3 guidelines so far. First one was published in 2010, second one 2012, just after 2 years, and the third one very recently in 2023. There's a gap about more than 10 years between these two. So first guideline, this was the 2010 guidelines, and then we have published another guideline in 2012, selecting this as there are some problems in the 2010 guidelines. So with this 2012 guidelines, we had a better understanding. Mortality has reduced, less ICU admissions, less complications. So you can see this is my ICU admission. In 2010, admission was 157. In 2022, it was only 11. You can see the admission as well as death rate has dramatically reduced after this 2012 guideline introduced. Now we have seen, if you think about the causes of mortality in dengue, before 2009 or after 2009, our main problem was fluid overload and compartment syndrome. Then over the years, it has changed. From 2013 onwards, what we have seen is overcautious fluid restrictions, which causes multi-organ dysfunction syndrome, and that's the main reason for death nowadays. So that is why we thought of publishing another guideline addressing these points. So 2023, we have published pediatric guidelines on the management of dengue hemorrhagic fever. This is the most recent guideline. Before starting this lecture, I have to emphasize these things. Dengue management is not try to give minimum amount of fluid. It is not somehow try to give only maintenance plus 5% fluid during the critical phase. But it is maintaining the hemodynamics with minimum amount of fluid. I think you can appreciate the difference between first 2 slides and the third slide. So we are concentrating about the maintaining hemodynamics, not about the fluid. So we want to maintain the hemodynamics, but not like in dengue, not like in septic shock, not like in other diseases. We are not free to use huge amount of fluid. So we have to maintain the hemodynamics with minimum amount of fluid. That is the key. That is the art. These are the take-home messages from this lecture. So we try to give minimum fluid in febrile phase, just sufficient fluid in critical phase, minimum fluid in recovery phase, and don't give unnecessary boluses, so that we can treat shock. In fact, we can prevent shock and avoid organ damage, and we can prevent fluid overload also. As I mentioned earlier, these are the 2 main causes of mortality in dengue. So we can prevent both. Don't forget, all the diseases are distributed in normal distribution curve. This Gaussian curve, you can't forget in medicine anyway. You can see most of the patients, about 68% of the patients can be managed with maintenance plus 5% fluid within guideline district hospitals. Some, about 2.5% of the patient, even with maintenance fluid, we can manage. But remember, there's another 2.5 here, the other extreme. They need more fluid. We have used maintenance plus 20% fluid, more interventions, thinking beyond guidelines, tertiary care hospitals, PICUs. So just because you are getting one patient, you can't say this patient is somewhere there. So it may be this patient may be in the middle, this patient may be in this corner of the curve, and this patient may be in this curve, this corner of the curve. So it's up to you to decide where this patient is, and depending on that, we have to select the proper management. For dengue to manage properly, we have to diagnose dengue early. So this is how you diagnose. Usually, we are diagnosing any disease with history, examination, and investigation. So dengue is a disease you cannot diagnose by history and examination. So you need investigation. So the very important investigation is this one. Very simple, full blood count, which is done on day 3. That is after 48 hours of fever. If you do a full blood count, if the full blood count shows white cell of less than 5,000, platelet count of less than 150,000, unless proven otherwise, that is dengue in Sri Lanka. There are so many other causes, but remember, this is the commonest reason in Sri Lanka these days. So day 3 full blood count, that is after 48 hours of fever, if the white cell count is less than 5,000, platelet count is less than 150,000, that is dengue. So we have to manage like dengue. And this is the admission criteria for pediatrics in dengue. If the platelet count is less than 150,000, we have to admit the child to a hospital to manage dengue. So what about this very famous, everybody is interested about NS1. So NS1 is an antigen. It's a non-structural protein 1. It's a part of the virion, part of the protein in the virus capsid. So we are taking this as an antigen. If you want to do this is the time to do it. Day 1 to day 3. Why? You all know what is the behavior of these antigens. You can see initially when the patient is getting disease, antigen is positive, antigen rate is going up, and gradually it is going down when the patient is developing antibodies. So here we can see the IgM is produced by the patient, and then later IgG is produced by the patient. So when the patient is producing antibodies, obviously antigen should disappear. So that is why if you want to do NS1, it should be day 1 to day 3. So best time is day 1 because after that it may be negative. So this is also very, very important concept. We know the problem of dengue in Sri Lanka is secondary dengue. First time dengue is like any other viral infection. We are not worried about the first time dengue. But in second time or third time, if you get the dengue fever, dengue virus again, you will be having problems. So to detect primary dengue, NS1 antigen is very, very good. To detect primary dengue, detection rate is more than 90% in primary dengue. In secondary dengue, what is the difference in secondary dengue? As soon as you get the virus enter your body will rapidly producing antibodies because this is a secondary disease. So you are already having memory of this disease. So body will produce antibodies very quickly so that antigen will be disappearing from your body very quickly. So secondary dengue antigen detection rate is 55 to 70%. So it's very low. So to diagnose dengue, especially the secondary dengue, antigen is not that useful. So it's like putting up a coin, 50% positive, 50% negative. So it's not that useful. So when you are diagnosing dengue with NS1 antigen, be careful. Remember about these things. Then this is also important. What is the difference between dengue fever and dengue hemorrhagic fever? So this nomenclature of hemorrhage or the dengue hemorrhagic fever is a misnomer. So the difference between DF and DHF is plasma leakage. So if you have plasma leakage, we call it DHF. If there's no plasma leakage, we call it DF. So that's the difference between DF and DHF. And this is the clinical course. So we all know there are 3 main phases of dengue hemorrhagic fever. There will be febrile phase, there will be critical phase, there will be recovery phase. If you go to the febrile phase, patient will have very high fever, 2 to 7 days, facial flushing, positive tourniquet test, hemorrhagic diathesis, enlarged liver. So it's like any other viral infection. They will have very high fever with various symptoms because of the fever. In critical phase, usually this is 3 to 5 days after the febrile illness. You will see rapid drop of temperature, capillary leak will start, abdominal pain, high hematocrit, low platelet, liver derangement, clotting profile, bleeding, hypoalbuminemia, respiratory failure, fluid overload. All the problems of dengue hemorrhagic fever are in this critical phase. That is why it is dangerous. Then you come to the recovery phase, you will see Ricci recovery rash, bradycardia, platelet count is going up, hematocrit is becoming normal. So basically it's recovering from the disease. So in dengue fever, we have febrile phase, we have recovery phase, but no red area, no critical phase. So it is not a dangerous disease. In contrast, dengue hemorrhagic fever, we have febrile phase, we have critical phase, we have recovery phase. Because of this red area, it is very, very dangerous. That is why dengue hemorrhagic fever is a problem. And we have categorized some patients with high risk category. So if the child is less than 1 year, high risk. Obese patients, high risk. Prolonged shock, bleeding, encephalopathy, underlying diseases, pregnancy. Those are the high risk conditions. If you think about the pediatrics, so we are having two main problems here. Infants and obese patients. Nowadays, children are very, very obese. Most of the patients are obese. So that's why our problem is high. So infants and obese patients from pediatric list are high-risk patients. And this slide is from Thailand. So what they are saying, if the patient is having prolonged shock, more than 10 hours untreated, death is inevitable. More than 4 hours untreated, if the patient develops liver failure, prognosis is 50%. Liver plus renal failure, prognosis is 10%. 3 organ failures plus respiratory failure, prognosis is a miracle. So that is why when you are managing dengue, it's very important to prevent shock if possible, or else treat shock as soon as possible without allowing it to go into the prolonged shock. Otherwise, management will be very, very difficult. So these are the main causes of death in dengue. So if you give more fluid, child will develop fluid overload. If you give less fluid, child will develop prolonged shock. So both are bad. Fluid overload as prolonged shock are bad. So that is why if you are giving just sufficient fluid in critical phase, not giving more, not giving less. So we are just giving the sufficient fluid in critical phase and prevent death as well as complications. So that is why our fluid management come to this summarized slide. So minimum fluid in febrile phase, just sufficient fluid in critical phase, minimum fluid in recovery phase. So again, I'm highlighting minimum fluid in febrile phase because we are not worried about the amount of fluid in febrile phase. Just sufficient fluid in critical phase because more fluid will cause fluid overload, less fluid will cause multi-organ dysfunction. So we have to prevent that. Minimum fluid in recovery phase. Again, we are not worried about the amount of fluid in, during the recovery phase. So main question is, how can we do that? For that, these are the important things. Just sufficient fluid in critical phase to achieve that goal. So we have to do these things. Identify the beginning of the leak correctly, predict the end, try to give maintenance plus 5% fluid during this time, and very, very importantly, match the leak. So this the last part is the very important thing. So if you are matching the leak, that means you are not giving more fluid, you are not giving less fluid. If my leak is 500 ml for last 1 hour, you are giving only 500. So you can't cause fluid overload, you can't cause organ perfusion also. It go one by one. How can you identify the beginning of the leak? So these are the suggestive things when the patient is entering into the critical phase, entering into the leaking phase. The platelets are less than 100,000. PCV is rising towards 20%. Patient will develop pleural effusion, ascites, low albumin, low cholesterol. If they are there, you know this patient has entered into the critical phase. So this is the beginning of the critical phase. And then this is also very, very important concept. So here, this is my febrile phase, This is my critical phase. This is my recovery phase. First, look at the platelet graph. Platelets are dropping during febrile phase, dropping. When the patient platelets are dropping below 100,000, patient is entering into the critical phase. Even in critical phase, platelets are dropping. Sometimes even in recovery phase, platelets are dropping. Then later, platelets are going up. That is my platelet graph. Now look at the white cell count graph. So initially white cell count is dropping. When the patient is entering into the critical phase, white cell count is rising. So you can see when the patient is entering into the critical phase, white cell count is rising. So if I can detect this point, platelets are still dropping, but white cell count is now started rising. That is the point of entry into the critical phase. That is very, very important concept. As pediatricians, we are so lucky because parents are panicked, treating physicians are panicked. So some of these patients are getting twice a day count, 3 times a day counts, 4-hourly counts. So as pediatricians, what we have to do is critically evaluate these counts to find out this point. Platelets are still dropping, white cell count is now started rising. So this is the beginning of the critical phase. So that is how you calculate the beginning of the critical phase. Then how to predict the end. So this is the natural history of the dengue hemorrhagic fever. So you are starting leaking here, gradually leak will go up. Maximum leak is usually around 24 hours. Then leak will go down. Leak will stop by 48 hours. So again, leaking start here, gradually leak will go up. We call it ascending limb, and maximum leak is around 24 hours where the patient can develop shock. Then leak will go down. We call it descending limb, and leak will stop by 48 hours. So this is my critical phase. This is what happens to the natural history of the disease. So if my patient is entering into a critical phase today till noon, I know till tomorrow till noon, patient is in the ascending limb. I'm expecting problems, expecting shock, expecting various problems around tomorrow till noon. Then leak should go down and leak should be over by day after tomorrow till noon. That is how you predict the end. Starting at today till noon, end day after tomorrow till noon. So that's the 48 hours. Then next one is try to give only maintenance plus 5% fluid during this time. The try is very important. We are trying, but sometimes we fail. So to do this, to give maintenance plus 5% fluid only during the critical phase, only during these 48 hours, you have to calculate the fluid for the adjusted body weight. This concept is introduced in 2021 guidelines. So 23 guidelines, calculate fluid for the adjusted body weight in obese children. Give only the amount needed to maintain hemodynamics. Frequent monitoring and adjusting fluid. And this is also very important. Don't give unnecessary boluses. These are the key to prevent unnecessary fluid during the critical phase. Why not give unnecessary boluses? We are talking about leaking bucket. There are so many holes in this bucket. If you rapidly fill this bucket up, more leak will be there, so that you have to manage your pleural effusion, your ascites more and more if you are giving more and more fluid as boluses. So don't give unnecessary fluid boluses. As I mentioned, this is the most important concept, match the leak. If you are matching the leak, you are exactly giving the same amount of leaking fluid into the patient. So you can't make fluid overload, you can't make poor organ perfusion. For that, your target urine output is 0.75 to 1 ml per kg per hour. This is for the new guidelines. And you are measuring PCV, you are measuring pulse volume, you are monitoring pulse, peripheral coolness, monitoring capillary refilling time, monitoring blood pressure. So we are monitoring these 6 parameters to get an idea about the organ perfusion, get an idea about the leaking. And this is also very important. Please don't treat only one parameter. You are measuring 6 parameters to get a holistic approach, holistic idea. So after measuring 6 parameters, if you are taking decisions only based on one parameter, that is useless. So please don't do that. Having said that, if you think about the PCV, if you have done the PCV, as a in the board setup, you know how cumbersome to do a PCV in a child. Sometimes you are squeezing, and only tissue fluids are coming, no blood. So you are putting this into the tube, capillary tube, and put some clay, put it to the PCV machine. Machine will evaporate half of this and give a number. So what is this number? I don't know. Pulse volume, as an intensivist, I will come and say, okay, pulse volume is all right. But a junior doctor will come and say, I can't feel pulse. Peripheral coolness is same, capillary refilling time is same. What about blood pressure? Nowadays is a digital era. So we are measuring blood pressure with digital meters. So what will happen? You are measuring with one machine. If the blood pressure is low, you are going for the second machine. Because you are thinking the quality of the machine matters. So you are asking for a better machine, or if you are using the Chinese machine first, go for the German or Japanese machine. So if that is also blood pressure is low, then you are going for the manual. Now we have 3 readings of blood pressure. So which one is correct? I don't know. So what I'm trying to say is all these parameters are subjective, depending on the machine's quality, depending on their experience, depending on your various things, you will get various numbers. Only objective parameter that you have is urine output. So if you have a catheter, if the catheter is not blocked, urine output is 5 ml for last 1 hour. That should be 5 ml for me, 5 ml for you. Even for the bystander, it should be 5 ml. So that's the only objective parameter that we have. That's why we are insisting on measuring urine output. So why we are measuring urine output? When you are having good urine output, we know our renal perfusion is good. If your renal perfusion is good, we know that our other organ perfusion also should be good. There are no diseases which can keep only renal perfusion good. So in other words, by measuring urine output, you are getting an idea about tissue perfusion. You are getting an idea about the cardiac output. So when you are having low urine output, that means your cardiac output is low. So please increase IV fluid. Don't give furosemide at this point, because urine output is low because perfusion is low. Perfusion is low because intravascular volume is low. So the treatment for low urine output in this context is fluid. If you give furosemide, one thing is you are reducing the intravascular volume further, you are asking trouble further, and you are losing this very important monitoring parameter. After giving furosemide, you can't say, okay, my urine output is now good, so I'm happy. So because this urine output is due to furosemide, which is forcing kidney to produce some urine. So don't give furosemide, it will give you a false security. That is why, because urine output is very important, we have put the indications for urinary catheterization. This was there from the first guideline from 2010. So all high-risk patients during critical phase need a catheter. Patient with first shock need a catheter. Patient with complication need a catheter. If the platelets are less than 50,000, you need a catheter. So these are very important indications. So if the indications are there, you need a catheter to maintain the good monitoring of urine output. So if you take this high-risk patient, so I told you first, less than 1 year, infant is a high-risk patient. So if the infant is having dengue hemorrhagic fever, you need a catheter. So definitely you need a catheter. Otherwise, somebody can sue you if something happens, because guidelines says you have to catheterize. If you are not catheterizing, that's up to you. So put a catheter, because it's very important to monitor urine output. Think about a patient who is not passing urine. So what will happen? So nurse will come and tell the HO, the child has not passed urine for last 1 hour. So then what will happen? HO will say, oh, some children are passing urine after 3 to 4 hours, so we can wait. So we are waiting, 2nd hour, no urine. Now we are informing your registrar also. So they are having a little bit of bigger brain. So they will say, okay, you can wait for another 1 hour. So 3-4 hours, no urine. So then what will happen? So after 4 hours, you are catheterizing, no urine. That means for 4 hours, child was in shock. Initially, I told you, if you allow patient to be in a prolonged shock, that's the problem that you are starting with. So please don't do that. If there's any problem, put a catheter and monitor the urine output. And this is also very important. The plasma leakage of dengue is very, very dynamic. It's not flat. So you can see initially plasma leakage is small, then it will go up. Maximum leak is around 24 hours, then it will go down, then leak will be over. So it's very dynamic. So you have to respect this. You can't just say, okay, you cannot generalize this. You cannot give a flat rate. You cannot give half the fluid in the first 24 hours. So some children are getting, some physicians are doing this. So you are calculating maintenance was 5%. This is 2000 ml. So we are giving first 1000 ml over 24 hours. Second 1000 ml over second 24 hours. You cannot do that because it's a dynamic process. So you cannot generalize the give the fluid rate. You cannot give flat rate. You cannot give half of the fluid during the first 24 hours. It should be decided by patient's clinical conditions and natural history of the disease. I told you, this is the natural history of the disease. So we have already discussed, you are starting leaking here, leak will go up. This is my ascending limb. Then maximum leak is around 24 hours. Patient can develop shock. Then leak will go down. This is called the descending limb, and leak will be over by 48 hours. This is how patient leaks. So if you are matching this leak, this should be my fluid chart. So initially, you are giving a small amount of fluid. Gradually, fluid rate should go up. Maximum amount of fluid is around 24 hours. Then fluid rate should go down. Minimum fluid after 48 hours. So basically, we are simulating the natural history of the disease. So if you are doing this, we are matching the leak. You can win always. Some patients are coming to the hospital late. So on admission, at TTUs we are seeing, on admission patient is in shock. So the patient is somewhere here. This part has already occurred at home. So you don't have to worry about this. So now the patient is here. So we have to look after from this point onwards. So on admission, this patient needs huge amount of fluid. You can understand this is the time with maximum amount of leaking. So you need more fluid during this time. Gradually fluid rate should come down, and 24 hours, after 24 hours, fluid rate should be minimum. So that's the natural history of that patient. So our fluid chart should be like this. So here we are giving huge amount of fluid on admission. Gradually fluid rate is coming down, and after 24 hours, we are stopping fluid. So that should be the way to manage patient admitted with shock. So again, we are simulating the natural history. So we are matching the leak. When the patient is having maximum leak, we are giving huge amount of fluid. When the patient is having less leak, we are giving less amount of fluid. But most of the patients are having this type of fluid charge. So can you manage dengue like this? No, you can't manage dengue like this. So we have to respect the disease. You have to adjust the fluid rate according to the patient's need. So these are the types of fluids that we are using in dengue. Most of the time we are using isotonic crystalloids for infusion and boluses. Either normal saline or ingress lactate you can use. And hypertonic colloid only for boluses. Nowadays we are using only 40% dextran. Earlier we were using hydroxylethyl starch, but it's not used now. Now we are using 40% dextran. That's the only hypertonic fluid colloid that we are using in dengue. And I have mentioned here is only for boluses. Please don't give infusions of colloid when you are managing dengue. So these are the indications of colloid. So if the patient develops shock, after two crystalloid boluses, you need a colloid. We are going to discuss this in detail later. If the patient is having shock, already having fluid overload, we can think about dextran, think about colloid, because otherwise you are heading to more fluid. If the child is having shock, going towards fluid overload, again we can think about colloid. And colloid administration, as I mentioned, I'm highlighting this again and again, only during the critical phase. No place for colloid in outside the critical phase. Only as boluses, no infusion. It should be a bolus, should be 10 ml kilo. No half boluses. Maximum 3 boluses in 24 hours, 6 in 48 hours. These are drugs. If you are giving more colloid, sometimes patient can develop renal problems. When the patient is not responding to conventional IV fluid treatment, so we are giving crystalloid, we have given colloid. In spite of that, if the patient is not responding, next we have to think about these 4 things: A, B, C, S. Acidosis, bleeding, calcium and electrolyte, and sugar. This slide is on Thailand. So our way of remembering this is A, B, C, S. Acidosis, bleeding, calcium and electrolyte, and sugar. Please think about these things when the patient is not responding. So bleeding. So this is another problem in management of DHF. So we can have two types of bleeding in DHF. Over bleeding, that is we can see the patient, see the blood. The second one is concealed bleeding. This is more common thing. So you cannot see the blood outside. So how can you know the patient is bleeding? So before that, managing of bleeding. So this is also to remember, management of bleeding in dengue is with blood. No other blood products. No FAP, no cryo, no platelet. We have to give packed cells. Blood transfusion is the treatment for bleeding in dengue. So indications of blood. If you see significant overbleeding, if the child is bleeding from mouth, hematemesis, melena, you can give blood. And this is what we call it concealed bleeding. Concealed bleeding means tissue level bleeding, but you can't see blood. So how can you suspect concealed bleeding? Your PCV drops without clinical improvement. So this is very important concept. In dengue, when the patient is bad, we know PCV is going up. When the patient is improving, PCV is going down. So here, PCV is dropping, but patient is not improving. So that's not tallying, not going in the same direction. So PCV drops without clinical improvement, that is bleeding. If the shock is not responding to crystalloid and colloids, that is bleeding. Endocrine dysfunction, despite adequate fluid, that is bleeding. And if you have liver failure early, so you can give blood to treat that. So these are the indications for blood transfusion in dengue. So how to give blood? We are always using in Sri Lanka packed cells, not whole blood. If you read the international guidelines, they say whole blood, but whole blood is not available in Sri Lanka. So you are giving packed cells. So you are using 5 ml per kilo, not 3, not 10. Again, this is misuse. If you want to give blood in dengue, it should be 5 ml per kg blood. That's the total amount. And this is also important. If you give 5 ml per kg blood, you increase your hematocrit by 5 points. This is very important when you are interpreting later hematocrit. If my PCV is now 30, I have given blood, the next PCV should be 35. The next PCV is 50. You cannot attribute this to this blood transfusion. 30 to 50, 20 rise cannot be achieved by 5 ml per kilo blood. So then it should be due to leaking. So leaking plus bleeding should be there for that to happen. Hypocalcemia, that's again common. It's a cause of conversion in dengue hemorrhagic fever. So that we are using empirical calcium in complicated DHF and deteriorating DFH. Again, not for all. This is not clinical medicine. Just because you are diagnosed in DHF, don't start on calcium. If the child is having hypocalcemia, you can start. Or if the patient is bad, you can start. In ICU, always you are using because all the patients are bad. So dose is this, 10% calcium gluconate, 1 ml per kg, maximum is 10 ml, dilute in equal amount of normal saline, double dilution, and give to the patient 6 hourly. That's how you give empirical calcium. Hyponatremia, again is common, cause of conversion in dengue, can cause cerebral edema and coning. So please don't use less than isotonic fluid in dengue. No N by 2, no N by 5, no water. So we have to use normal saline in dengue to prevent hyponatremia. It's a killer. I told you, this is the natural history of dengue. So if you are managing properly, this should be my fluid chart. Basically, we are simulating the natural history of the disease. The patient is admitting with shock. This is the natural history. Admitting here. And this should be my fluid chart. Again, you are simulating the natural history. You are matching the lead. But unfortunately, what we are seeing in ICU is this type of fluid charts. Then I thought, I have to think about patient, the treating physician's mentality, why they are using this type of fluid time to time. So what is happening here? Initially, we are giving, okay, you are diagnosing leaking, you are starting patient monitoring and starting fluid. So you're giving small amount of fluid, 2 ml per kilo of fluid. All of a sudden, child develops shock. You're treating with normal saline. After giving 10 ml per kilo of fluid, child becoming better. Then you are cutting down fluid back to 2 ml per kilo. Just remember, now 2 ml per kilo is not enough. That is why this patient has developed shock. That is why we have to give fluid bolus. At least at this point, we have to increase the amount of fluid because 2 ml per kilo is not enough to match the leak. That is why this patient is developing shock. So at least we need a higher amount of fluid. So we are not doing that, giving the small amount of fluid. And next, again, next shock, you are giving dextran. Again, same thing. After the dextran, child is improving, you are cutting down fluid to back to 2 ml per kilo. And again, third shock, you are giving normal saline, giving blood, sent to MIC. Why this is happening? You are so worried about the amount of fluid that you are giving. You try to minimize the fluid. By doing that, you are repeating this shock. So when you are repeating the shock, patient's multi-organ dysfunction can occur. So management will be very, very difficult even in MICU. That is why I told you management of DHF is not try to give minimum amount of fluid. It is not somehow try to give only maintenance was 5% fluid during the critical phase. It is maintaining the hemodynamics with minimum amount of fluid. I think you can appreciate this slide's message. So our concept, our main objective is maintain the hemodynamics, not the amount of fluid. And we are very happy to see this type of graph. Initially small amount, gradually fluid rate should go up. Maximum fluid is around 24 hours, then fluid rate should go down. So that's the way to manage dengue. And this is one patient that we have managed. This is our ICU. You can see this patient is having a ET tube. Patient has 2 IC tubes, 2 PD catheters. So 3 organ failures with respiratory failure. Outcome will be, the prognosis will be very, very bad. The outcome was death. So we don't want this to happen again and again. So that's why we need to concentrate early detection and manage dengue properly. That is why we have published this 2023 guidelines. I'm going to highlight the main differences, main changes that we have made during 2023 guidelines. That is fluid calculation in obese children and target urine output. These are the main changes that we have done from 2012 to 2023. Fluid calculation, we are now going by 3 weights: actual body weight, ideal body weight, and adjusted body weight. So if the patient's actual body weight is less than ideal body weight, actual body weight is less than ideal body weight, you can take actual body weight. If the patient's actual body weight is slightly above the ideal body weight, actual body weight is little more than ideal body weight, you can take the ideal body weight. There's a marked discrepancy, actual body weight and ideal body weight. You are not taking ideal body weight, you are not taking actual body weight, you are taking the adjusted body weight. Now think, just to elaborate on this, my patient is 100 kilos, the ideal body weight is 50 kilos. So this patient is eating and drinking for 100 kilos at home. All of a sudden, when the patient is admitted with dengue hemorrhagic fever, we are telling the patient, no. You can't be eating for 100 kilos. Your body weight should be 50 kilos. It's not going to work. That's why we thought it should be in between. Actually, not actual body weight, not ideal body weight. It should be in between. That is why we took this adjusted body weight. This is how you calculate the adjusted body weight. 0.4 into actual body weight minus ideal body weight plus ideal body weight. So if I do some mathematics, so if the actual body weight is 48, ideal body weight is 37, so adjusted body weight is 41.4. It's in between actual body weight and adjusted actual body weight and the ideal body weight. This is in between. That is how you calculate the adjusted body weight. In obese children, we have to use this adjusted body weight. This is again from the guidelines. Golden rules in the management of critical phase. Early detection of beginning and recognizing the end of plasma leakage is important. We have discussed that. Meticulous monitoring, matching the fluid administration to the leak fluid. We have discussed about the matching the leak. Anticipation, early detection, and treatment of concealed bleeding and other complications. That's the key in the management of dengue. Our urine output target now is 0.7 to 1 ml per kg per hour. Earlier it was 0.5, but we have increased now to 0.75 to 1 ml per kg per hour. Urine output, it should be milliliters per kg per hour. No point telling me, okay, this child has passed 25 ml last hour. Depending on the weight, it changes. Is the best guide to deciding the rate of fluid infusion. 0.75 to 1 ml per kg per hour is sufficient to maintain renal function. Dextran, again, this is from the guidelines. Key points on administration of colloid administration. Dextran 40 is recommended only during the critical phase. It should only be given at a rate of 10 ml per kg per hour over a maximum period of 1 hour. And this is how you manage. This is the algorithm of management of dengue shock. So I'm going to give a little bit of time for this. So I'm taking part of it. You can see patient with shock can be having two types. Shock with narrow pulse pressure. That means we are discussing about the compensated shock. And you can have profound shock or unrecordable blood pressure or pulse. The management is different. So first we'll think about this part. Shock with narrow pulse pressure. That means compensated shock. You are giving normal saline. Dose is 10 ml per kg over 1 hour. After 1 hour, you are reassessing the child. There may be response. There may be no response. If the child is having response, adjust rate according to the hematocrit, pulse, capillary filling time, blood pressure, urine output. Important thing is, don't try to restrict rapidly. If you are giving 10 per kilo of fluid, if there's a response, reduce it to 7, another 1 hour, reassess. Everything is all right, coming back to 5. Likewise, gradually you have to reduce. Don't reduce rapidly. If there's no response, you are giving the second bolus. If there's no response, you are giving the second bolus of normal saline, again over 1 hour, reassess, there will be response or no response. After second bolus, if there's response, same thing. Adjust the fluid rate according to these parameters. If there's no response, even after second bolus, if there's no response, this is the time to give Dextran. To Dextran 10 ml per kg over 1 hour, you are reassessing again, so there will be response or no response. If there's response, again adjusting the rate according to the clinical parameters. If there's no response, so we have given first bolus 10 per kilo normal saline, no response. Second bolus 10 per kilo normal saline, no response. Third bolus Dextran 10 per kilo over 1 hour, no response. Then you have to think about A, B, C, S. Acidosis, bleeding, calcium and electrolyte, and sugar, and manage accordingly. So it's very simple. Now we are coming back to the other side. So we have already discussed the shock with narrow pulse pressure. That means compensated shock. Now we are going to discuss about the profound shock or unrecordable blood pressure pulse. Here the difference is, if the pressure is unrecordable, you can't feel pulse, it's a rapid bolus of normal saline, 20 ml per kilo, free flow, until you can feel the pulse. So again, it's not 10 per kilo, you are trying to give 20 ml per kilo fluid as a free flow until you feel the pulse. So you may be feeling pulse after 20 ml per kilo, you may be feeling the pulse after 10 ml per kilo, you may be feeling the pulse after 15 ml per kilo. So if there's a response, what to do? If there's no response, what to do? So if there's a response, you are reducing fluid to 7 to 10 ml per kg over 1 hour. Initially, we have given 20 per kilo until the free flow, until you feel the pulse. Then you are gradually reducing the fluid. The second hour should be 7 to 10 ml per kilo. Then adjusting the rate according to the clinical parameters. If there's no response, now we have given 20 ml per kilo as a free flow. Even after 20 ml per kilo, no response. Then Dextran, like previous one. So there we have given 10 per kilo twice. Here we have given 20 ml per kilo as a one bolus. So after 20 ml per kilo, if there's no response, the treatment should be Dextran 10, Dextran 40, 10 ml per kilo over 1 hour. You are reassessing. So if there's response, again, reduce gradually fluid rate, 7 to 10 ml per kg per hour over 1 hour. Adjusting rate according to the clinical parameters. If there's no response, again, you are thinking about A, B, C, S. Here, we have given 20 ml per kilo normal saline as a bolus initially. Since there's no response, we have given the second bolus like Dextran, 10 ml per kilo, 40% Dextran, 10 ml per kilo. Even after that, if there's no response, think about acidosis, bleeding, calcium and electrolyte, and sugar, and manage accordingly. So this is what we have already discussed. Is there in the guideline. Anybody interested, you can download this guideline from EPID unit website. It's freely downloadable. I think patients, people who are managing dengue in Sri Lanka, you should know in and out of the current management of dengue published by college and the epidemiology unit. And a little bit of complication, the things, management of complications. Some people are interested about this, how to manage fluid overload. So there, it's very important to get an idea about the intravascular volume. Sometimes you will have fluid overload. That means more fluid is there in your body, but not in the correct place, not in the intravascular compartment. These fluids are mainly in pleural space and the peritoneal space, useless. So intravascular volume status is crucial. So intravascular compartment may be depleted despite the patient being fluid overloaded. So this is very important concept. So when the fluid overload is there with depleted intravascular volume, if you give furosemide alone, it's very dangerous because intravascular volume is already depleted. If you are giving furosemide, you are reducing this further. That is very, very dangerous. There, first give dextran, restore the intravascular volume, and then give furosemide. If you have a fluid overload with good intravascular volume, then you can give furosemide alone because intravascular volume is good. And this is also a very important concept. In dengue, what we have seen is it's very, very sensitive to furosemide. So you can't use the normal doses of furosemide. Your furosemide dose should be very low. Usually we are using 0.1 milligrams per kg as a bolus. Usual dose is furosemide is 1 to 2 milligrams per kg. Here we are giving 10 times less dose. So 10% dose in dengue because they are very, very sensitive and can be repeated if necessary, but don't give huge dose, normal dose at the beginning. So this is also very important. HLH, hemophagocytic lymphohistiocytosis. It is treatable if identified early. Mortality is very high if you delay the diagnosis. Should be suspected in management of dengue. This is how you suspect. Ongoing fever with multi-organ disease involvement. Usually in dengue hemorrhagic fever, what we have seen is when the patient is entering into the critical phase, your fever is going down. If the fever is continuous, even with the critical phase and multi-organ dysfunction, think about HLH. Secondary HLH is common entity in dengue hemorrhagic fever. So bone marrow biopsy is necessary to diagnose. Treatment is dexamethasone or methylprednisolone. So better to discuss with hematologist and pediatric oncologist if you are suspecting HLH. Dengue in obese children, again, this is a problem. That's why we are calculating fluid for the adjusted body weight. You are calculating urine output for the adjusted body weight. You have to catheterize early, consider colloid early, consider blood transfusion early, empirical calcium gluconate, and consider expert opinion early because this is not a joke. And we are going to discuss two brief cases, real cases, just to elaborate the concepts that we have discussed. So this child, 8 years, weight was 40 kilos, admitted to district hospital on day 2 of fever. Dengue in his son was positive. First shock was detected on day 4. Child had melena and puncture site bleeding, transferred to LRH on latter part of day 4. So this is how they have managed. Normal saline is 5% dextrose, 2 ml per kilo for 11 hours, 2.5 ml per kilo for 9 hours, 5 ml per kilo dextran, that is so-called half boluses 3, and 10 dextran 10, that is full boluses 1, and then coming here. So I just put this into the chart. You can see initially we were giving small amount of fluid, then 1 dextran, second dextran. Just concentrate about these things. Urine output. No urine, 0.6, 1.4, 0.4, 0.4, no, 0.3, 0.4. So 1, 2, 3, 4, 5. So 5 hours, urine output is not adequate. That means 5 hours, child was in shock. So initially I told you, if the child is having without treating, keeping shock for more than 4 hours, its outcome is very, very poor. So by looking at this chart, I can say outcome is poor. What has happened? they have monitored very nicely. You can see the PCV. PCV is gradually increasing 48, 47, 50, and urine output is coming down. So this is good indication saying that, okay, I need more fluid. Fluid rate is not enough. You are giving very small amount of fluid. So because of the fear to giving more fluid, they have not given fluid. So not catheterize, not match the leak, ignore the pulse rate, urine output, and PCV. So this is the kind of situation when the patient is entering into the ICU, saturation 85, dyspneic, periphery is cold, pulse volume very high, low volume, rate is high, and blood pressure is low, abdomen distended, PCV is 42. So this is what happened. Initial SGPT is 67, it has gone up to 7,000 odd. 41 SGOT has gone to 28,000 odd. Child died with liver failure. And second one, again, similar patient, 16 kilos. This was the admission date. Directly admitted to the ICU because of the father, the mother is a consultant. So we directly admitted, she wanted to admit to the ICU directly. So we have also done the same thing. So we have given 3 ml per kilo of fluid as a flat rate. But we were monitoring very carefully. You can see, so urine output 1.8, 1.5, 1.2, 0.75, 0.71. So we were giving 3 ml per kilo fluid. Initially, child is producing 1.8 urine. Now child is producing 0.75 urine. So you don't have to have a big brain to say, okay, now the child is leaking. And initially 3 per kilo is not enough. Now it's become not enough. So we have increased to 5 ml per kilo. So after increasing 5 ml per kilo, now urine output is 1.2, 2.6. 5 ml per kilo is too much, isn't it? Now we thought 5 ml per kilo is too much. So we reduced it to 4. So even with 4, child is producing good urine output, 1.4, 1.7, 1.8. Then we thought, okay, come back to 3. But after reducing to 3, it's become 0.9. So this exercise showing us that this child's leaking is between 3 and 4. 3 is not enough, 4 is a little bit higher. So anyway, we decided to go for the higher level. So 4 ml per kilo, then we have to give blood, we have to give dextran. So patient is relatively unstable in sometimes, but this is what happens. And at the end, SGPT 49 has gone to 103, SGOT 108, 110 has gone to 225. This child went home. So that is why now I am telling difference between life and death in dengue is urine output. If you are maintaining urine output without furosemide, they will go home. If they cannot maintain urine output, child will die. So these are the common pitfalls. Not simulating natural cause of the disease. Try to give minimum amount of fluid. Cutting down fluid just after bolus. Not try to prevent shock. Not giving blood early. Not sending the child to ICU early. Because we are providing critical care, not fulminant care. These are the take-home messages. We have already discussed this. Minimum fluid in febrile phase. Just sufficient fluid in critical phase. Minimum fluid in recovery phase. Please don't give unnecessary boluses in the management of dengue. So that we can treat shock, we can prevent shock. By doing that, we can avoid organ damage and we can prevent fluid overload also. As I mentioned, these are the 2 main causes of dengue, the 2 main causes of mortality in dengue. So if we can prevent both, child should go home. So thank you very much. We are seeing this type of patient. We like to see this type of patient, not like previous child. I'm very happy to answer if there's any questions.
So there are a few questions in the chat box. The first question is, what is the role in series of ultrasound scan in diagnosing dengue leaking?
That's a very good question. Actually, ultrasound scan can be used to diagnose leaking. So it is only one thing. So if the leaking is there in ultrasound scan, we know that child is entering into the critical phase. So you can use it, but serial ultrasound scan just to diagnose leaking. But after leaking has started, I don't think we need to do serial scans.
Another question regarding scans. Is gallbladder wall edema still a reliable indicator of plasma leakage?
So when we are discussing about these scans before producing these guidelines, no consultant radiologist has evidence saying that this is it. So if there's leaking is there, you can say, okay, child has started leaking. But otherwise, other things, some people believe it, some people not. So important thing is going by the clinical parameters.
Is there any significant change in the neutrophil count when there is bleeding?
Yes, that's a very good question. Neutrophil count can go up. Usually, white cell count is low in dengue. If you have high white cell count, when the patient is ill, you have to think about bleeding.
Can we go beyond the calculated fluid quota in the critical phase if needed?
Definitely, yes. That's what I'm trying to highlight. The guide, this is only for the guide. So maintenance as 5% is guide. So sometimes we may have to exceed that. Sometimes we don't have to use that amount. So it's just only a guide. So we have used maintenance plus 20% fluid. Still, children have gone home because if there's a massive leaking, you cannot just stop by maintenance as 5%. Definitely, you can exceed if necessary.
Is there no place of platelets in bleeding in dengue hemorrhagic fever?
Usually, there's no place for bleeding. Having said that, sometimes if the bleeding is there due to coagulopathy, sometimes some children can develop DIC. In that case, we can discuss with hematologists and give some platelet, FFP or cryo, depending on the parameter, depending on the investigation. Usually, what we do a thromboelastogram in that case. Then we can decide what to give. But 90% of the chance, it is not necessary. We are managing dengue bleeding with pack cells only.
There's another question. The last one is, what is the management of acute liver failure during this dengue hemorrhagic fever if there's any?
So there's no difference between dengue causing acute liver failure management and acute liver failure management in other causes. Our aim should be prevent acute liver failure. If the patient is having acute liver failure, that means you have not managed dengue properly. So when you are managing dengue properly, there shouldn't be acute liver failure because liver failure is due to poor perfusion to the liver in dengue. So if you are maintaining the perfusion with correct management, there shouldn't be acute liver failure.
There's another question. Can we take the reduced urine output at night as physiological when we are managing dengue?
Always I am getting this question after this lecture. So it's very, very dangerous. We all know there is a possibility of reducing urine output early part of the night, early part of the morning because of the ADH secretion, but it's very dangerous. My answer for that question is, if this is your child, what would you do? So I am very happy to give a fluid, and if the child develops fluid overload, I can manage fluid overload. As an intensivist, I am very happy to manage fluid overload than multi-organ dysfunction. So I would give fluid rather than waiting, thinking that this is physiological.
That's all for the questions, sir. So I would like to thank Dr. Nalin Kitulwatte on behalf of all of us. I'd like to extend our sincere thanks for your invaluable lecture on the management of dengue hemorrhagic fever. Your clear, evidence-based approach and practical insights into this critical care management were incredibly informative and timely. We truly appreciate the time you took out on your demanding schedule to share your expertise with us, and your guidance will undoubtedly enhance our clinical practice and improve the patient outcomes. Thank you once again for your time, knowledge, and the dedication in advancing in pediatric critical care. Thank you, sir.
Thank you very much.
There is a link in the chat box to get the post-assessment questions. You can kindly give us your feedback and answer the post-assessment questions to receive your e-certificate for your participation. We thank you very much for your participation and warmly welcome you to participate in a session next Saturday with another interesting topic. Thank you very much. Have a good week.